So much on the opioid abuse situation, and today on the show, we're going to talk about just how bad it is and how one major U.S. health system is taking a tremendous step in leading the charge to reduce opioid prescribing and save lives. If we don't do something about it fast, we're talking about an estimated 650,000 people dead in the next decade. We've got these leaders on our show today, and we're going to dive in deep. It's a power-packed episode of Red Hot Healthcare. Let's go.
This is Red Hot Healthcare. Interviews with today's leaders and all the news that matters. Here's your host, Steve Ambrose.
Hello and great to have you aboard. I'm your host, Dr. Steve Ambrose. For past and upcoming episodes, find us on iTunes and most podcast directories, or on our eye-catching website, redhothealthcare.com.
This episode of Red Hot Healthcare is sponsored by Walk the Ridge. 71% of doctors said that this contributed to their medical errors. 66% of employees reported that their job performance declined because of this. What is it? Incivility. And walktheridge.org is a social movement promoting the practice of civility. Visit walktheridge.org today and download our free guide that you can put to use for your health system, hospital, or business. Employees deserve dignity, respect, and civility, and your company deserves better results. walktheridge.org. Today on the show, we have Dr. David Hasleton and Mikelle Moore, two leaders from Intermountain who are spearheading the charge on opioid addiction. Dr. Hasleton is Intermountain's Associate Chief Medical Officer and has been with them since 2004. He will be one of the guest speakers at the highly anticipated Opioid Management Summit in Washington, D.C. Mikelle Moore leads Intermountain's prevention and community health improvement efforts, and she also oversees their extensive and successful efforts in population health. David and Mikelle, I want to welcome you both to the show. We're going to have a very engaging back and forth, I suspect.
Thank you. We're excited to be here.
Yeah, thanks for having us.
I want to go ahead and jump right on in. Dr. Mark Harrison, who's the CEO of Intermountain, said, and I quote, "We know that 142 Americans die every day from drug overdose. Over the course of the Vietnam War, we lost 53,000 Americans. Now we're losing more than that every year to drug overdose, including opioid-related deaths." That was a pretty staggering stat. Another stat that I read was that opioid misuse nationally, because it's exploding, we can expect that within the next decade, if uncontrolled, we're looking at more than 650,000 future deaths due to opioids. Both of those numbers staggering. First, I'll go ahead and start with Mikelle. Do you have any other stats that you think would really open our audience's eyes to just how severe opioid addiction and the opioid problem is today?
Sure, Steve. Thank you. I think what first caught our attention in Intermountain several years ago was that drug poisoning deaths had surpassed deaths due to firearms, falls, and motor vehicle accidents in Utah. And we know that's true in most states. We also made some observations about the number of pregnant women who are receiving prescription opioids. That was shocking to us. It's about 23% of pregnant Medicaid recipients nationally. And in our state, it's even higher, about 41%. We also have seen an increase in the amount of opioids people are prescribed in America. The number of opioids prescribed per person is about 3 times higher than it was in 1999. And the thing that I guess concerned us and drew us into this as well is that in Utah, and I think this is true in most states, it's estimated that only about 10% of those with a substance use disorder receive substance use treatment. And we know opioid use disorder is likely underreported. So those numbers are pretty staggering, and was certainly a call to action for our health system to become involved with our community in this work.
Yeah, that 10% number really is staggering. David, why don't you jump in? Do you have any other stats that are pretty eye-opening?
Yeah, just a few thoughts. When you talk about the amount of deaths from opioids, 40% of those opioid deaths come from prescription opioids. And we know that the overdoses from opioid deaths have quadrupled since 1999. And really what that equates to is 91 people die in this country every day from an opioid overdose.
That's amazing. So let's step back for just a second if we can. And a lot of the listeners on the podcast today are going to be healthcare professionals, or they're going to be business professionals that are just familiar with operations in healthcare. But there's a number of listeners that we have on the show that are healthcare consumers. And I'd like to just take a little step back if we could here. And David, I'll throw this to you. Why don't you give the audience just a quick down and dirty on how opioids work, why they work so well on pain, and then the mechanism perhaps on why they're resulting in addiction.
The way opioids work, there are certain cells within the body, in the brain, in the spinal cord, and even in the muscles and other tissues of the body that have what's called an opioid receptor. It's a place where an opioid, such as morphine or oxycodone, when that chemical gets in the body, it rests on that receptor.
Right.
And it helps the body blunt the pain response. What's also interesting is the body has a natural mechanism to make that happen, and those are called endorphins.
Right.
So when the body experiences pain, it triggers automatically endorphins that block the sense of pain to some degree, and it's different for certain people, and that's certainly based on genetics. But when you take an opioid, it has a stronger and more powerful blunting effect. And there are certain opioids that actually may increase the endorphins or the number of pain receptors blocked by 100 times, therefore giving you a much more strong pain blocking mechanism.
Gotcha.
The addiction happens, though, if you think about an opioid creating 100 times the pain blocking effect that your natural body will do, it actually decreases the body's own endogenous endorphins. And so over time, your body will not release those pain relieving mechanism any longer. So when you withdraw an opioid from your system now, you'll go into withdrawals, and there's a whole cascade of addiction that happens after that.
So what you're really saying is, and I want to make sure I'm clear on this, is by taking opioids, and especially over the long term, what winds up happening is your own endorphins or your own what would be an innate or internal opioids actually start to shut down and allow themselves to get replaced with what you're taking orally. And then over time, are you saying that they don't come back or they simply stay low while you're taking the opioids?
Well, they do come back over time. And so there's a difference between tolerance or dependence and addiction. If you take an opioid for a certain amount of time, and that's different for everybody, and again, that's a genetically based process. Taking an opioid over time, if you get to a point where you're no longer experiencing the same pain relief from the same dose of opioid, that means you've developed a dependence or tolerance to it, and you need more and increasing doses.
Gotcha.
So yes, it shuts down the body's own endorphins, but if you withdraw that unnatural endorphin or the opioid, over time, the natural opioids or natural endorphins will return, certainly.
Intermountain is making a really solid charge. One of the things that is consistently been reported, and I would add quite well from your communications end, is that you've put a goal out there of reducing the number of tablets and prescriptions, opioid tablets, for acute care conditions, and you're looking at reducing that number by 40%. And that's a pretty bold goal. And then additionally, you trained already more than 2,500 caregivers on opioid prescribing. I think you've even added some alerts into your EHRs. What's the number, or roughly the numbers, that are broken down for people that take opioids that have acute situations or acute health conditions versus chronic? And then maybe how many of those break down to getting addicted?
You know, as we've looked at this problem within Intermountain, there's certainly a correlation between acute and chronic use of opioids. Prescribing rates nationally are highest among pain medicine and surgery, some of the places you would expect them to be high. However, overall, primary care providers account for about half of the opioid pain relievers that are dispensed in our country. So primary care providers end up providing a lot of the medications to help people manage pain over time. And it's very difficult to separate acute and chronic users from a health system perspective in our data. We've begun registering patients in our chronic pain database, and that's helping us to make that distinction. But the data nationally is not necessarily organized very well between acute and chronic because it's been so hard to capture that. Of our chronic pain documented patients, about 13% of those are being prescribed medications that shouldn't be prescribed at the same time as an opioid medication, according to our claims data. So we've really looked at how do we manage this issue from both an acute prescribing, and you mentioned some of the things Intermountain's doing, and I know Dr. Hasleton can speak to this. We want to change the number of tablets we're prescribing for acute care conditions, and we also want to change prescribing in those chronic conditions for areas where there could be mixing of medications that would be inappropriate and unbeknownst to the different caregivers involved in a patient's care.
David, you want to jump in on that a bit?
Well, she brings up a really good point, and our focus on this co-prescribing is benzodiazepines along with opiates, which is a deadly combination. And I'll just say this, that there was a New England Journal of Medicine article published in 2016, which talks about the prevalence of chronic pain, which in older adults, it's actually a little over 40%. And so we know that's a significant problem in our society, and they also indicate that over 30% of Americans have acute or chronic pain. So it's hard to differentiate a little bit acute and chronic in the statistics, but it's very clear that a significant portion of the American population has an acute or chronic pain issue for which they're receiving opioids.
Yeah, and it's certainly growing, that's for sure, and chronic conditions are growing too. I know that we've interviewed on our past shows some members from Cerner. John Glaser was a show guest, and he talked quite a bit about the new electronic health record that I believe Cerner and Intermountain are working on together. And really, I bring that up solely along this end, this new smart EHR, because as I understand it, one of the things that you do with opioids too is you start integrating some flags or alerts within your EHR. Is that correct?
Yeah, I can speak to that one. We've developed a database or a dashboard of sorts that gives a provider their own specific information for how many opiates they've prescribed, what's their average per prescription, to whom they prescribe these, and we're working on more information that gives them what's called morphine milliequivalents per dose. So all of this goes into the new Cerner product that we've used and developed here to help the provider give them better information to help the patient when they really need it.
And when we talk a bit about opioids and when people are addicted, it may not always be obvious to them that they are addicted, or maybe even obvious to others. So, Mikelle, I'd like you to go ahead and step in on this question here. And I want to just ask you, what are the signs that people should be looking for that they may be addicted, or a loved one or a friend may be addicted to opioids?
So we refer to this condition as opioid use disorder. And, part of our reason for using that terminology is to try to reduce stigma around it. But certainly that disorder, the symptoms are recognized as, first, a strong desire for opioids, which seems fairly obvious, but an inability to control or reduce use. And that would be as well continued use despite interference with obligations, social or family functions, use of larger amounts over time, so development of tolerance, and also then spending a great deal of time to obtain and use opioids. That might appear in going to multiple doctors or spending time trying to access medication. And then, of course, withdrawal symptoms. And the withdrawal symptoms could be negative mood, nausea or vomiting, muscle aches, diarrhea, fever, insomnia, those types of things.
I know that one of the more common, it's getting better now, obviously, as we tie databases together, but I guess for years, people were simply doctor shopping when that ability was there to go ahead and slip under the radar, right?
Right. And I think most states are trying to do things to prevent that. And certainly as our electronic health records become more accurate and enable ease of reporting, that becomes easier.
David, tell me a little bit about the speed of dependency, of over-dependency, or why don't we just call it addiction? How fast does this happen? I mean, I come in for an acute condition and I'm prescribed opioids in some form of medication or some drug name brand. If I'm going to develop dependency and addiction, let's say, how fast can that happen?
You ask a really good question, and you bring up the 2 points of emphasis. Because simply dependence does not necessarily mean addiction, or dependence or tolerance you can really lump together, but they're on a spectrum. So, for example, an individual who has surgery and they have their gallbladder removed, let's say they have a bottle of 40 Percocet given to them in the post-op phase, and they take this within the next 7 to 10 days. That can actually create a dependence or a tolerance to that. There's a genetic component to addiction and a tolerance, certainly, but we first develop tolerance first, and then it goes into an addiction phase. And it's variable for everybody. That's why this is really hard to pinpoint. But we always recommend that we provide the lowest possible dose to get the patient out of acute pain and then follow different modalities thereafter.
And now, a message from our host. Red Hot Healthcare was a side hustle that started for me back in January 2017. I'm pleased to have had tens of thousands of downloads and show listeners who are some of the top healthcare leaders and influencers. However, my full-time career focuses on adding tremendous value for healthcare organizations. I'm happiest when filling the needs of those I work for and with. You can learn more by visiting my consulting page at redhothealthcare.com/consulting or reach out to me directly by emailing steve@redhothealthcare.com. And now, back to the show. Look, I mean, opioids obviously work in the sense that they obviously help pain, and there's a lot of people in chronic pain, as you mentioned. 40% of all adults have some sort of chronic pain of some type, very common. So let's say we cut this down by 40%. What's the substitute? What comes in now for those people who are in a lot of pain and they need relief, and maybe, simple over the counter or maybe some other common prescriptions aren't going to do it for them? Has Intermountain thought about, what the options are there?
We have decided it's really important for us to create a distinction between how we're managing acute pain and chronic pain. And when we describe our 40% reduction goal, it really is around acute prescribing. And based on a study that we did, actually, of our surgical patients who we learned were using less than half of what we were prescribing. And so if we can reduce the number of pills that people are prescribed for a post-surgical intervention or in the emergency department for something that has affected them very recently, we can reduce the risk of someone becoming dependent or for those pills being used by someone other than the person they were prescribed for, which is one important part of moving upstream of addressing this issue. Then there's the broader issue of how do we help people manage pain? And Dr. Hasleton can speak more to it medically, but I can say from a community collaboration perspective and making services available, there's a few things that we think are important. One, we need to increase the availability of comprehensive pain management resources. We are starting clinics and offering community-based classes for chronic pain self-management that are very reliable, tested by the CDC, and we're implementing those in our communities, and also improving access to treatment. We know treatment works. Medication-assisted treatment has a great evidence base, and we're integrating that into the way we provide primary care for people so that it's a part of the way that we are assessing needs and then addressing people's health needs in their primary care setting where they're taking care of their other well-being components.
As a practicing emergency physician, there is not one day that I work in the ER that goes by that I don't have some sort of pain-related concern with a patient, meaning they come in for pain and they want relief. Low back pain is a significant problem in our country for various reasons, and we tend to see a lot of low back pain in the emergency department. We have implemented a care process model years ago, and have been successful at moving people away from using opiates as a first-line therapy. So we refer them and actually help them through our case managers to get into physical therapy. We then offer nerve blocks, and we have educational components, as Mikelle talked about. So we look for every opportunity not to use opiates at all, especially as a first-line treatment. And this goes back to taking care of the patient, because in the long run, they will be much happier than if they received an opiate as the first thing they receive for their low back pain.
Let's get into culture. And David, I read an article about you. You actually were being interviewed, and you mentioned in the article that the opioid problem we have today came from a long cultural history that built up in years past. And I'd like you to explain that.
The culture behind opiates is multifaceted and very complex. But years ago, in the early 1990s, pain was being looked at a little more closely to help a patient in the setting in which they found themselves. It was something previous to that we didn't do a great job of addressing. So in 1995, 1996 timeframe, the American Pain Society adopted pain as the fifth vital sign. And soon thereafter, this caught on nationally. The Veterans Health Administration and the Joint Commission recommended that pain be a fifth vital sign. And so when the Joint Commission jumps on board, they recommend to hospitals that they address pain as a significant quality measure. In addition to that, CMS has adopted as part of their quality measures in the HCAHPS, or the Hospital Consumer Assessment of Healthcare Providers, that pain is rated as a quality issue by the patient. In other words, the patient gets a survey and they're asked to respond to how well their pain was controlled. Now, hospitals are given their feedback to say if you didn't treat pain well enough, then CMS may withhold some reimbursement for not doing a good enough job at treating pain.
Right.
So that's some of the background behind the culture shift. So what it created was a whole lot of demand to treat pain without providing the prescribers an educational component on how to actually treat the pain.
You know, it brings up a point that we hadn't discussed before, but one that just comes top of mind for me, and that is that in this age of consumerism now, which has largely been thrust upon a lot of hospitals and health systems and providers in a surprising way. You know, for years past, you talk about culture, and I'm a bit of a history buff on the history of the for-profit fee-for-service system. Many health systems really did not treat patients as customers. I mean, they served them, of course, but they really treated the insurance companies as the customers, not the patients. And of course, the hottest thing right now in healthcare is consumer-centered care, largely because it's the patient's dollars are the first dollars, typically with higher deductibles, right? So one of the things is, for better or for worse, we do have some of that trailing history with the HCAHPS, with the fact that it's linked to payment, like you mentioned. I think in the long run, that has, although it's changing now, I think that has definitely done a disservice, because it's sort of just created pain as a necessary thing you have to fix, but only now are we sort of seeing the results long term.
Well, and Steve, you are exactly right. But prescribers were never taught how to treat pain very well. And so the easy answer was, let's give an opiate. We know that it treats pain, but we didn't do it well because of all the side effects and ramifications downstream.
And Mikelle, I'm going to segue right into you now with this, because we did talk about this prior to the interview. It is a hot subject. We won't get red hot into it, but we'll at least get a little warm. And that is with David talking about the fact that, a lot of providers didn't know about just how dangerous the opioid medication could be in terms of its addiction or addictability. Now what's happening, as anybody who's reading the healthcare news, is there's lawsuits. You've got counties like Harris County, Texas, that is filing lawsuits against pharmaceutical manufacturers, and the counties are claiming that the pharma companies knew that their drugs were addictive. They knew they were dangerous, and they withheld the information, not just from patients, not just from federal and state officials, but also from doctors themselves. I would like to get, Mikelle, your thoughts on this since you are inpatient and community health and obviously does have some bearing on our community.
It does, Steve. And in Utah, we do have some counties that are considering and filing lawsuits, just as Harris County, Texas is. And these are our friends and colleagues filing these lawsuits. We have great empathy for the burden they're bearing in the community. They're trying to provide treatment resources through Medicaid dollars and even some services for unfunded through county resources. And the demand has increased dramatically for first responders, whether they're providing naloxone and overdose or trying to create access to treatment. The burden has increased significantly without an increase in funding. They feel great pain, and we really empathize with them in their ability to meet the needs in the community. We're pretty focused, though, not on the blame factor. As you mentioned, we're really focused on how do we work forward from here? What do our communities need in order to get upstream of this issue and deal with the crisis already underway?
Last week, there was research that came out that suggested that the deaths from opioid overdoses may be the biggest factor, the number one factor, driving an overall decline in U.S. life expectancy. And there was a gentleman named Bob Anderson from the U.S. Centers of Disease Control and Prevention. And in looking at the 2016 data, this is what he said, quote, "We could have more than 2 years of declining life expectancy in a row, which we haven't seen since the influenza pandemic of 1918. And I was reeling when I read that. And Mikelle, you head up population health at Intermountain. How is Intermountain applying population health technology and techniques into the opioid addiction issue? I mean, apart from the lowering of prescribing and the teaching of the providers, what are you doing with the communities and engaging them, and maybe what types of results are you seeing there?
Thanks, Steve, for asking. And yes, those data points that Bob Anderson commented on are pretty shocking. And it's actually the reason that Intermountain decided to focus on this as one of our community health priorities a couple of years ago, as we looked at what was affecting the health of Utahns and others in our country. We could see that opioid misuse was likely to continue to be one of the significant issues addressing mortality and morbidity in our community, and thought we needed to move upstream to address it, which is really the principle of that we're trying to use within population health overall. And as we think about how to improve health in the community, our strategies are to identify the issues that are most important to address in terms of the needs of our community, and then think about the resources that we can help bring together from the community perspective as well as Intermountain resources to make a difference. As we talked with people in the community about what we could be doing and what others could be doing and how we might coordinate together, we saw a lot of opportunity related to opioid misuse. So you've heard a little bit about what we're doing inside of our organization with prescribing and creating alerts in our electronic health record, et cetera. We are also integrating mental health screening for substance use into all of our primary care settings, including with pediatric providers, starting at age 13. And then we're also embedding medication-assisted treatment into primary care settings. We've had a demonstration project underway for about 16 months in our community and have 352 people actually in treatment as of today. Our part of our work in that demonstration project is to help our government colleagues in the Medicaid program, as well as primary care providers within Intermountain, see the results of medication-assisted treatment with a population here in Utah. We've had remarkable results. There's about 52% retention in the program compared to about 13% in treatment as usual, which is therapy without medication. And with those in medication-assisted treatment, we have about 91% abstinence from opioids at the 16-month mark.
That is absolutely phenomenal.
Yeah. And so treatment works, and we know that there's not enough treatment available right now. And so we are setting goals within our own primary care practices to increase the amount of availability, and also working with a lot of community providers to increase access there as well.
David, I'd like to throw this question to you. I know that Kaiser lowered opioid prescribing as well over the last several years. That was an initiative that they took on too. And I want to ask, just from the perspective of an integrated health system versus a non-integrated health system, which most health systems and hospitals are non-integrated today, do you think that it makes a big difference in the ability to really get these sort of results that you're seeing now? In the fact that when you have an integrated system, you can take on something like this big Megillah of opioids and be able to more successfully get the results and the benchmarks you're looking at?
That's a really good question. And I think that the key to an integrated system is how quickly and efficiently the ship can be turned, so to speak. It's possible also with those who are affiliated with a system to make the same changes, albeit it takes longer to do it, because oftentimes goals and incentives aren't aligned. With Intermountain Healthcare, we have a fairly integrated system here, so for us, it is a little bit easier, but we also have affiliated providers who are working lockstep with us, and over the years, we've developed great relationships that they now have incentives and goals aligned with Intermountain. So it will be easy for us because we've already set the foundation years ago for this cooperative effect.
Yeah, absolutely. Mikelle, did you want to add something to that?
Sure, I'd be happy to. I think, within our system, it has been easy to engage. Our pharmacies all dispense naloxone without a prescription and offer secure medication disposal drop boxes so that our community they have places to go to dispose of medications when they're finished. Select Health, which is our insurance arm, educates its membership on safe storage of medication and disposal, and they only cover 7 days of medication for acute conditions. So we have great reinforcement of what we're trying to create as a health system with various components. And then beyond the health system, I think even if we didn't have all of these components, we would be trying to do these things. And for example, we are funding the public awareness campaign in our state, trying to influence how the public perceives the danger and risk of opioids, as well as improve their understanding of safe storage, safe use, and safe disposal. And all of our public awareness campaign development, we're sharing with the health departments, the counties, prevention coalitions, et cetera, so that we're increasing reach. We're giving funding to community pharmacies that Intermountain doesn't own to establish drop boxes. And we're sending our pharmacists out into rural communities to educate first responders and distribute naloxone so that we can really partner with our community to bring some of the resources that are outside of our integrated system to bear on this problem as well.
One of the things it brings just to my mind now is, and we hadn't discussed this before, so I'm sort of throwing this in, but I interviewed Steve Klasko. I don't know if you're both familiar with Steve or know Steve personally from Jefferson. He's quite the innovator and the CEO of that health system. And we talked on the podcast about business models and the importance of understanding trends and then really being strong in leadership of health systems and hospitals. And today it seems like that those health systems that really understood trends years ago, they didn't just look to make, and I don't want to cheapen it, but it didn't just look to make the fast volume-based buck on, fee for service and just get out as much as they could and bill. But they really understood what was coming down the pipe in terms of chronic disease, in terms of cost. It seems like Intermountain, Kaiser, Jefferson, and others really have the right business models. And more than that, they really had them years ago before they, now everybody has to have a model like this just to survive with the profitability rates that are decreasing. But I just have to say, in doing the research on some of the organizations like Intermountain, I'm really impressed with the leadership you all have. And maybe if you all would just care to share your own thoughts on that.
I just share my thoughts from a provider perspective, let alone a physician leader. I have been impressed over the years when I first joined Intermountain Healthcare back in 2004 that I as a provider had the ability to care for a patient who had no ability to pay. And I was encouraged to do the right thing for the patient, to give them the appropriate care, and then get appropriate follow-up with one of our providers despite the ability to pay. That was a system in which I wanted to work and that I could flourish in as a provider. That is what Intermountain Healthcare stands for.
I might add, if it's okay, Steve, Intermountain has organized around something we refer to as clinical programs, thinking through best practices in delivering care to patients, regardless of ability to pay, but also regardless of remuneration to the system. And years ago, started looking at the variation in induction of labor and the relationship between when labor was induced and NICU stays. And we've talked in lots of different audiences about that migration to a standard of not inducing labor before 39 weeks, even though it reduced NICU stays significantly in our own hospitals, which we were paid well for. And this opioid epidemic that we're talking about, we can see in similar ways. Now, the biggest driver of expense in our NICUs is opioid dependency. We're again looking at doing this for the right reasons.
And I don't have an issue with profitability. As far as I'm concerned, if you're not breaking the law, if you're adding value, if you're helping people rather than hurting them, make billions of dollars as far as I'm concerned. But if you're hurting the system, if you're hurting the experience, if you're just in it for the personal gain, that's where the problem is. So I think you can do the right thing and still get great results financially, and you all are proving that. I want to jump in now to an area that has gotten a lot of press recently. In fact, it's gotten a lot of press as of this taping, and that is cannabis. And of course, states with medical cannabis have seen through their dispensaries, they've seen a 15 to 35% decrease in admissions to substance abuse centers, specifically for opioids. So, Dr. Oz has spoken about this on his show. Senator Orrin Hatch from Utah, your own state, and many leaders are considering very strongly the possibility for utilizing medical cannabis to help the opioid crisis. The Utah Patients Coalition, it appears, is going to get a signature ballot, 113,000 signatures they need to actually put medical marijuana on the state ballot in November. So I think currently there's about 29 states that have legalized medical cannabis. You work for a large health system. I think Utah is one of the higher states in terms of opioid abuse in the United States. And, there's a religious aspect in Utah. We certainly have to know that too. And then the federal and state laws. Let's start with you, David. First of all, your thoughts a bit about some of the studies out there with cannabis and maybe cannabis as a possible solution for opioid addiction.
Well, you do certainly bring up a hot topic. We look to the community, the medical community. We look to data. We look for outcomes and best practices to really prove to see if this is what it says it is. For example, years ago, again on opiates, it was felt that heroin could treat morphine addiction. Well, soon thereafter, it was discovered that heroin was more powerful than morphine was. So we're cautious, first of all, to say we will follow best practice and medical science to make the right decision. That's really the stand that we take. We are in favor of helping patients and communities.
Right.
And we will do whatever we can to help communities at large to improve their own health.
Yes. And a final question here. Apart from Intermountain's impact on the state of Utah, and clearly you all are not only doing excellent work in your state, not only in your hospitals, but in your communities, where do you see that your organization can make a bigger impact nationally?
That's a good question. We are excited to share this, and we've had many other health systems approach us in our opioid practices and what we're doing and best practices. We want to be leaders in research regarding appropriate prescribing habits because we know there's very little data out there that tells us how many opiates or opiate equivalents should we be using after gallbladder surgery or what have you, any kind of surgery or procedure. We want to educate more providers and the public in general. We want to be national advocates for change and use the government as partners to help with that change. and develop cost-effective alternative treatment options to using opiates.
Dr. David Hasleton and Mikelle Moore from Intermountain Healthcare. I want to thank you both so much for coming on to Red Hot Healthcare today. What a terrific show. So much insight into what's going on today with the opioid crisis. And I am really not only impressed, but I'm really hopeful that all the great work Intermountain is doing is going to spearhead not only great results for you all and for the state of Utah, but really serve as a terrific benchmark for other health systems. So again, thank you for coming on the show. Very much enjoyed having you, and I look forward to hearing great things about Intermountain in the coming year.
Thank you, Steve. The pleasure was ours.
Thank you, Steve.
You've been listening to Red Hot Healthcare with Steve Ambrose. Subscribe to us on most major podcast directories. For media or business inquiries, reach out to media@redhothealthcare.com. Thanks for listening. This is Denny Colonna. We're out of here.